Hello there. Many thanks for inviting me to give this talk. I wish I could be there in person, but circumstances don't allow it, perhaps next year. So today I'm going to be talking quite a lot about consciousness. And clinically, when we talk about consciousness, we're really thinking about two different concepts. One of them is wakefulness and the other is awareness. And actually, we measure them in completely different ways. Wakefulness is very easy. If your eyes are open, then you are awake. But awareness is much more complicated to assess. And just because somebody's eyes are awake, it doesn't mean that they are necessarily aware. And in this context, what I mean by awareness is aware of who you are, where you are, and the situation that you're in. And as I'm going to show today, these two components of consciousness, wakefulness and awareness, are dissociable. And perhaps the condition in which this is clearest, I suppose, is the so-called vegetative state, which is often referred to as a condition of wakefulness without awareness. And that's because these patients will often open their eyes. They have roving eye movements. They'll appear to sort of look around the room, but they won't fixate on anything in particular. They often have normal sleeping and waking cycles. But the most important aspect of this condition is they will not respond to any form of external stimulation. So you ask them to squeeze your hand, they won't do it, or look this way or that way. Beyond basic reflexes, there's no response to any external stimulation. And this is the basis upon which it has always been believed that these patients lack awareness. Now, I've always thought this exposes quite an interesting conundrum as far as assessing consciousness is concerned. And that is that the only way that we really have of knowing that somebody is aware is if they are able to tell us that. And if they're not able to tell us that they're aware, well, up until recently, we could never know. And that's one of the things I'm going to repeatedly touch upon in the rest of this talk. Now, we set about almost 20 years ago now, trying to look at whether any of these patients who were diagnosed as being in a vegetative state had any residual cognitive function. And in the early days, what we would do is simply expose the patient to something in the scanner. And these were studies with functional magnetic resonance imaging, or fMRI. And here's just a summary slide from a couple of our papers that came out in Brain in 2007 and 2009. And here we were looking for speech-specific responses. So we would play the patient bursts of speech, normal speech in the scanner, and we will compare it to signal correlated noise. And that's basically noise that has many of the same basic acoustic properties of speech, but it doesn't sound like speech at all. And by looking at the difference between responses to these two conditions, we're able to establish whether the brain has any specific speech or any speech-specific response. And as you can see here in the top left-hand corner, that's what you expect to see in a healthy participant. Bilateral activity in the middle and temporal gyri. It's most often strongest in the left or the dominant hemisphere. And here's a large group of patients who are diagnosed as being in a vegetative state. And as you can see, many of them show quite normal responses to speech. Not all of them, but some of them show responses that are actually not significantly different than those that we see in healthy participants. In fact, as you can see from this pie chart at the bottom, about half of the patients that we scanned over a number of years would show normal speech-specific responses. Now, what to make of this? Does it mean that the patients can understand the speech? Do they know that they're hearing speech? Well, we answered that question with this study that we conducted with colleagues in Cambridge in the UK in 2007. And what we did here is we took a group of healthy participants and we gradually sedated them using the anesthetic agent propofol. And that is while they were listening to these same speech stimuli and the signal correlated noise, because we wanted to see what actually altering a healthy person's awareness would do to these speech specific responses. So that's what you've seen previously, bilateral activity in the middle and superior temporal gyri when the participants are awake. When they're mildly sedated, well, really not very much happens. And in fact, even when they're deeply sedated with propofol, we still see these speech specific responses in the appropriate areas of the brain. Now, yeah, there are tiny differences between these patterns of activity as we reduce levels of awareness. But if you do a direct comparison between, there's absolutely no statistically significant difference. And that is because your brain will continue to process speech as speech, even if you are demonstrably unaware, even if you've been rendered unconscious with propofol. And of course, that tells us something about this pattern of activity that we might see in a patient who's been diagnosed as being in a vegetative state. And And what it tells us is that, well, yes, although we can say that the relevant areas of the brain are intact, the areas of the brain that process and perceive speech, it tells us nothing about awareness. Because if these healthy participants who are deeply sedated and demonstrably unaware show that pattern of activity, then we obviously cannot conclude that vegetative patients have any awareness based on these patterns of activity. Now, that's not to say that these types of early fMRI experiments were redundant or useless. Actually, we learned some very interesting things about them. One is that if you do show these types of fMRI responses in the scanner, then you have a better chance of recovery. Now, I haven't talked about most of these conditions, but if you simply group the patients that we saw over those years into those who produce no responses, those who would produce responses to sound, only, those that will produce responses to sound and speech. And a condition here I haven't talked about, a speech comprehension condition, those who actually show evidence of speech comprehension. What you find is a very nice correlation, not between their current clinical status, but their clinical scores 6 months from now. So if you can show these responses in the scanner, then you have a better chance of some recovery 6 months from now. So this fMRI data is, of course, is prognostically useful, even if we can't conclude that a participant has any awareness based on the results. Now, this is where we moved into a different type of approach. In 2006, we reasoned the following. Well, these patients, by definition, cannot respond behaviourally, physically. They won't make any response to external stimuli. But could they make a response with their brain? And the idea here was based on a bedside examination. And we know that often if we're trying to work out if a patient is aware, we'll say, well, squeeze my hand if you can hear me. And the idea here was, well, let's ask a patient to activate their brain if they can hear us. We first tried this in a patient who'd been in a road traffic accident. She'd been vegetative for a few months at the time that we saw her. I won't go into detail about how we came up with these ideas. There were many studies involving getting here, but one of the main things we did is we asked her to imagine that she was playing a game of tennis. And this is simply a vehicle to get people to imagine making vigorous upper body and arm movements, because we know in healthy participants, as you can see in the top left here, this produces strong, reliable activity in the premotor cortex. This is something that we can see in individual participants. We've done this in hundreds and hundreds of people over the years, and it's extremely reliable. Now, our patient, who apparently was vegetative, could produce exactly the same activity. When we said, imagine playing tennis, the premotor cortex lit up. When we said, well, now relax, activity in that area went away again. Rather as though we were saying to her, well, squeeze my hand now, stop squeezing my hand. Squeeze my hand now, stop squeezing my hand. But of course, she couldn't do that. But it turns out that she could activate this particular area of her brain when asked to do so. When we switch tasks to something else, spatial imagery, and in this task we ask people to imagine moving from room to room around their own homes, and that produces activity in a lateral area of the premotor cortex, the parietal cortex, and the parahippocampal gyrus, an area deep in the brain that's often referred to as the parahippocampal place area. And when asked to perform this task, the patient could do, she could activate all three of those regions: lateral premotor cortex, posterior parietal, and the parahippocampal gyrus. Again, demonstrating that she could respond to command, not behaviourally, but with her brain. Now, on the basis of these data, we concluded that this patient was not in a vegetative state at all. She was in actually some previously undefined sort of complete locked-in situation where she was actually entirely conscious, but completely unable to produce any behavioural responses whatsoever. And not everybody bought that story. Some people said, well, perhaps just simply saying to somebody, imagine playing tennis, could sort of fire off an automatic pattern of brain responses that are associated with imagining playing tennis without the patient having any knowledge of that actually occurring or any conscious experience of imagining playing tennis. And we refuted that with this, I think, rather interesting study we carried out simply to satisfy the reviewers at the time. We put a group of healthy participants in the scanner and we said, okay, imagine playing tennis. And there's the traditional, the classic SMA, medial premotor activation that we were now used to seeing. Then we said to people, okay, now we're going to tell you to do some things, but we want you not to do this. And the same participants still in the scanner. So we said, please do not follow the instructions that you're about to hear. And we said, imagine playing tennis, exactly the same instruction. And this time we saw no activity in the premotor cortex. And this is because imagining playing tennis is not an automatic activity, no more than squeezing a hand or raising an arm into the air if asked to do so. To imagine playing a game of tennis when asked to do so, you have to voluntarily enter into the study, if you like. You have to actually carry out this task in your brain. And this really was conclusive evidence for us that this patient wasn't just automatically playing tennis. She was willfully or voluntarily taking part in the study and producing this pattern of activity when we asked her to do so. Another piece of evidence, of course, is to look at what happens in propofol. We know with with speech perception that nothing happens when you sedate people with propofol. But we did the same thing with people imagining playing tennis. And if you just look at the right-hand column here, this is the sort of angle that you're most familiar with, sagittal slices through the brain. There's the premotor activity when people are wide awake imagining playing tennis in the scanner. Again, these were healthy participants, gradually sedated with propofol, all the while being told to imagine playing tennis. And even at low levels of sedation, activity has clearly dissipated. In fact, it's almost disappeared completely in this area. And even when they're, or at least once they're moderately sedated, activity in the premotor cortex has disappeared completely. And actually this fits very well with the experiences that people report when they are going through this study. Early on, they'll say, well, it's fine, I'm imagining playing tennis, I'm doing what you said. Later on, you say, well, how did it feel to imagine playing tennis when you were heavily sedated? And they really don't have any conscious memory of it at all. Now, of course, this is just correlational. It doesn't mean that you absolutely can't imagine playing tennis when you're unconscious, but we know of no data that supports the fact that you can. And these were really the different approaches that we used to really conclude that this was the task that could reveal patients who were covertly aware, patients who appeared to be vegetative behaviourally or clinically at the bedside, even when assessed by experienced neurologists. Yet, in the scanner, they could produce these patterns of activity. Now, over the next few years, we tried this in many, many patients who were diagnosed as being in a vegetative state, and we concluded that about 1 in 5 of them in the scanner could perform these tasks, could imagine playing tennis. So it's not the case that all patients who appear to be vegetative are actually conscious and aware, but certainly it looks like about 1 in 5 or 20% of them actually are. Now, this is not just data from my own laboratory. In 2016, in the Green Journal, Conziella and colleagues published data from many, many labs around the world that are now using our task or versions of our task. And again, with over 1,000 patients studied using these active mental imagery tasks in the scanner, about 20% of them turn out to not be what they appear to be at all, turn out to be conscious and aware and able to perform these tasks. Now, how can it be? What can the mechanism be? How can a patient be able to imagine doing something, but not actually be able to carry it out themselves? And the answer to that came from one of my former postdocs, Davinia Fernandez-Espero, who is now on faculty at Birmingham University. And Davinia did a very elegant series of 3 MRI studies, or at least 3 studies using different MRI approaches. First, she used fMRI, as you can see here, to compare actually playing tennis with imagining playing tennis. Now, obviously, you can't actually play tennis in the scanner, but she did the next best thing. She hung a tennis ball in front of the participant, and every time they were instructed to do so, they had to reach out and hit it as though they were playing tennis. And in the imagery condition, they simply had to imagine that they were doing that. By comparing the two, she could look at what's the extra thing that you need to actually actively play tennis as opposed to just imagining it. And what's extra, and that's what you're looking at here, is activity in the supplementary motor area, the primary motor cortex, that won't surprise anybody, and the thalamus. In fact, areas of the thalamus that project to M1 and the supplementary motor area. Now, the next part of the study was to use dynamic causal modeling to look at the functional connectivity between those different areas as people are either actually playing tennis or imagining playing tennis. And the difference between the two, what is the difference in terms of the functional connectivity? And what Davinia was able to show is that an area, in fact, a projection from the thalamus to M1, an excitatory projection from thalamus to M1 is essential for the execution of these purposeful movements over and above what is required for imagining these movements. So it's thalamus to M1. Now, the third part of this experiment was really the proof of principle. And here she used diffusion tensor imaging, which, as most of you will know, looks at the tracks, the physical tracks connecting different areas of the brain. And what Davinia did is she looked at 2 patients One who we knew could imagine playing tennis, but was nevertheless entirely behaviourally non-responsive. And that's patient number 1 in this graph on the right-hand side. And then she looked at a patient who was recovering, was now in the minimally conscious state, could actually produce some responses to show that they are aware. I haven't said this already, but the minimally conscious state is a condition that vegetative patients often emerge into, where they can show some evidence of awareness, but not enough for them to be able to communicate systematically with the outside world, but it's nevertheless clear that they are actually aware. And the biggest difference, she looked at these 2 projections, one from the thalamus to the supplementary motor area, and one from the thalamus to M1. And what Davinia was able to show is that the greatest damage in the patient who could imagine playing tennis but couldn't physically respond was in this projection, this projection from the thalamus to M1. So I think this explains why these patients exist. In some ways, it's a bit like a disconnection syndrome. If you are unfortunate enough, for whatever reason, to get damage to this projection from the thalamus to the primary motor cortex, then you can be put into this extremely unfortunate situation where you are able to imagine doing things. You're able to experience the world. You're presumably able to perceive and comprehend speech, but you can nevertheless produce no physical or behavioral responses to any form of external stimulation. Now, the next step in this journey was to try and actually communicate with some of these patients. This was a patient that had been in a vegetative state, supposedly following a motor vehicle incident for 5 years. This was a study conducted in collaboration with our colleagues in Belgium, in Liège. The patient was scanned there. If you look at the left-hand side, there's the sort of canonical response in healthy participants to imagining playing tennis at the top and imagining walking around your house. The bottom, that's the parahippocampal gyrus down there, the lateral premotor cortex. Now, this patient, when we asked him to imagine playing tennis, produced a pattern of activity very similar to the pattern that we see in controls. When asked to imagine moving around the house, the patient produced a pattern extremely similar again to controls. Now, the patient's brain, as you can see, is severely damaged. As we see in a lot of these long-term vegetative patients, there's a lot of atrophy. The ventricles are very much enlarged. But this is the beauty of fMRI, because you can superimpose the functional data on the structural data. You can very clearly identify anatomical structures. In his case, we were able to show that he's clearly activating the parahippocampal gyrus and the lateral premotor cortex, just like healthy controls when asked to imagine moving around his house. What we then said is, okay, we know that you're aware, we know that you can hear us, we want you to answer some questions. Imagine playing tennis if the answer is yes. Imagine walking around your house if the answer is no. And we got some information from the family of the patient. We were given questions that we didn't know the answers to, and there were things like, what is your father's name? And we had a series of options, and we asked the patient, is your father's name Alexander? As you can see, in this case, he produced a pattern of activity very similar to the pattern observed when he was imagining playing tennis. And he's not being asked to imagine playing tennis here. He's being asked, is your father's name Alexander? But he knows that to say yes, he has to imagine playing tennis. On this basis, we concluded that his father's name was probably Alexander. But let's compare it with another condition. We asked him, is your father's name Scott? And in this case, he produced a very different pattern of activity, the lateral premotor cortex and the parahippocampal gyrus, clearly indicating that he was imagining walking around his house, because he had to imagine walking around his house in order to convey a no response. And we went back and checked with the family, and it turned out, yes, his father's name was Alexander and his father's name was not Scott. We asked a whole series of questions like this, and he performed very well. He was able to answer a whole series of questions about who he was, the relatives that he had, even the last place he'd been on vacation 5 years earlier, just before he'd had his injury. Now, in other patients, and this was a proof of concept. The idea was we had to answer questions that we could independently verify. So we didn't necessarily ask things that were pertinent to his care, but we've gone on to do that in many other patients. And this is just illustrative data, so that I can get through this quickly. But this is from a patient that we saw who'd been in a vegetative state for 12 years, seen every year by a neurologist, continuously, a very experienced neurologist actually, and continuously diagnosed as being in a vegetative state. We asked him to imagine playing tennis. Clearly, he could do it. And in his case, we scanned him many, many times over a series of months, and we were able to ask him many questions about his welfare, and some questions that I think we were able to work on or improve his standard of living. For example, do you still like watching hockey? Here in Canada, a lot of people watch hockey, or ice hockey, as we call it in the UK. The problem with many of these patients is they get put down in front of the TV and shown an awful lot of whatever it is they used to like before they had their accident. And perhaps 12 years after his accident, this patient didn't want to watch any more hockey. As it turns out, he was able to answer yes. He imagined playing tennis and wanted to play hockey. Another example, we ask all patients this now: are you in any pain? Because pain, again, it's a purely subjective thing. You cannot independently verify whether somebody is in pain or not, other than asking them. And we ask our patients whether they are in pain. And this guy was actually the first to go through that procedure, and on 2 occasions he responded that he wasn't in any pain. So these are the sorts of questions. Obviously, we can't bring people out of their vegetative state yet, but we can at least ask them questions that I think can perhaps make them more comfortable, can improve their standard of living. Now, one of the big problems here is that many patients will undoubtedly slip through the net. We know this because we've seen patients that haven't been able to imagine playing tennis, and sometimes have gone on to recover, have been aware early on in their condition, and we haven't understood why they couldn't imagine playing tennis. And it's probably because it's extremely cognitively demanding. The patient has to think about tennis for 30 seconds and then relax for 30 seconds, think about tennis for 30 seconds. So more recently, we've explored ways of passively deducing that somebody is consciously aware without them having to actively do anything. And you've probably been watching this early Alfred Hitchcock movie for the last couple of minutes. It's a movie about a boy you see here who finds a gun under his uncle's bed. It's actually a real gun. You know it's a real gun, but you also know that he thinks it's a toy gun. He's running around the house playing cowboys. It's typical master of suspense stuff. You realize somebody's going to get shot at some point. It's extremely tense. To follow this plot involves a lot of cognitive operations. You have to have some theory of mind. You have to know what the kid thinks. You have to, know that guns kill people. You have to have some sense of foreboding, what's likely to happen in the future. There's a lot of foreshadowing goes on, as is very typical in Hitchcock movies. And working on some research that was carried out by a guy in the States, Uri Hasson and his colleagues, who used some early moving watching, we figured, well, if we could show that a patient was actually following the plot of a movie, isn't it a reasonable sort of leap of faith to say, well, then they can follow the plot of their life, which essentially means that they're conscious. Now, the methods here I'm going to go through very, very quickly, but essentially, if you ask a group of participants to all watch this movie in the scanner, obviously at different times, but you line up all of their brains, what you find is they're very highly correlated. So the activity you're looking at here in the bottom is not brain activity. It's voxels in the brain that are significantly correlated across 12 individuals who are all watching this movie. And some of these areas of the brain are obvious. It's obvious that visual cortex is going to be correlated. When shades of light and dark change, it's the same for everybody. When the gun goes off and everybody hears that bang, everybody's auditory cortex is going to fire at exactly the same time. But what we were more interested in is these sort of higher cognitive areas in the frontal lobe and the parietal cortex. What are they doing? Are they following the plot? And in fact, through a series of studies, and this is from another one of my former postdocs, Lorena Nachi, who is now on faculty at Trinity College Dublin, through a series of studies, Lorena was able to use a statistical technique called independent component analysis to pull out these different networks in the brain, to isolate the frontoparietal network, and to actually show that, yes, this area of the brain is responding to things that are occurring in the plot itself, over and beyond the basic perceptual aspects of the movie. It's not sound, it's not vision, that's going on in auditory cortex and visual cortex. It's actually twists and turns of the plot. And again, I don't have excuse me, I don't have time to go into the methods in detail here, but what you're looking at with all these lines in the bottom right are different participants, and it's showing you that activity in this network of the brain is very highly correlated across individuals, and that activity or that correlation is linked to specific twists and turns in the movie. And to cut a long story short, a few years ago, we started seeing patients. And what Lorena did, actually, in the first paper that came out in PNAS in 2014, was she compared two patients who were clinically quite similar, but one of them that we knew was aware. So these were two supposedly vegetative patients. One was actually, we knew was aware through other techniques. A second patient had produced no responses at all. The patient who produced no responses in the scanner, when we did this task, again, so these are, in yellow here is the auditory network, in blue is the visual network, and in red is the frontoparietal network. And you're looking at areas of the brain that correlate with those areas in healthy participants. And in the patient who appeared not to be aware, not to be conscious, all we saw was a correlation in the auditory cortex. And this fits with the data I showed you early on, that things like speech perception is preserved irrespective of levels of awareness. But this patient, the patient that we knew that was aware, produced correlated activity, not only in auditory cortex, also in visual cortex, but crucially in fronto and parietal cortex. And this showed us that this patient is following the plot of the movie. They're following the twists of the turns. They understand the movie. And again, in this case, excuse me, the conclusion that we were able to reach is that therefore this patient can follow the plot of their own lives. They are actually, they're actually conscious. And this is the method that we've used subsequently to identify awareness in many patients who supposedly are vegetative, because it's cognitively far less demanding than the imagined playing tennis task that I've spoken to you about already. Now, in the last part of my talk, I'm going to switch slightly to talk about a different condition, talk about coma. Up until now, I've talked about the vegetative state. I've talked a little bit about the minimally conscious state. Coma is a condition, I mean, the media often confuse coma and vegetative state, but actually it's quite different. Coma is a condition that occurs typically before the vegetative state. In the first few days after a very serious brain injury, you might find yourself in hospital in a coma. Typically you'll have eyes closed, no sleeping and waking cycles. Like the vegetative state, there's no responses to any external stimulation. So in a sense, then they appear to be both unaware and unawake, unlike the vegetative patients who are awake but unaware. Now, this is much of this work has been carried out by another of my former postdocs, Loretta Norton. Loretta is now on faculty here at Western at King's College. What Loretta and I were interested in is, well, can any of these techniques that we've used already in the vegetative state be useful in coma? Can they improve diagnosis and prognosis in coma? Now, this is a really important issue. In some ways, much more important than doing this work in the vegetative state, I think, because in conditions like the vegetative state, as I've shown you, many of these patients can survive for many years. Obviously, they have to be fed and hydrated, but they're not being kept alive by so-called life support systems. So when they are allowed to die, it typically involves a court case and a sort of a protracted series of decisions and events by the family and the attending staff. But in coma, it's much different. Many coma patients will be withdrawn. They will have life support withdrawn because a decision is made that the likelihood of any meaningful survival is low, or death is likely, and so they will be withdrawn in advance of natural death. And the question is, can we improve the on the techniques that we have available for making those sorts of decisions? So for the rest of my talk, I'm actually going to go over many of the same methodological approaches that I've told you about already. So I won't give you a lot of methodological detail. I'll just tell you what the results are in a few coma patients. So let's look first at things like speech perception. That's in the middle column here. Speech perception, sound perception, and language comprehension. I briefly spoke about at the beginning of my talk. Now, this is from a study of 17 patients that Loretta looked at. It turned out that 9 of those patients produced evidence of speech perception. I'm only showing you 4 patients here because these are the patients who actually went one level higher than that and produced evidence of speech comprehension. But 9, about half of the patients who are comatose, again, in the acute stages of a brain injury, the first few days after arriving in the ICU, 9, about 50% of these patients produced evidence of speech perception. There's 4 of these cases here in the center column. 4 of 17 patients produced some evidence of language comprehension. But as I've said previously, and this is very interesting as far as understanding what areas of their brain are still intact and are still responsive. But remember, it tells us nothing about awareness because these are all automatic brain processes, even language comprehension. It's an automatic brain process. You can't decide to not understand what you are hearing right now, assuming that you're a native English speaker. Speech comprehension is completely automatic. It's something you cannot control. It's outside of your conscious control. Similarly, as we showed in the chronic vegetative patients, these fMRI responses in the scanner in comatose patients are related to your likelihood of recovery. It turns out that when you plot whether you have no responses, just responses to sound, speech, or language comprehension against the Glasgow Outcome Scale, how good was your recovery? There is a significant relationship between the two. So it does have prognostic value, and that's, I think, going to be extremely important in this population of patients. Now, here's one patient who was able to imagine walking from room to room in her house. Now, this was a patient who was in a coma at the point that she was scanned. She couldn't produce activity in the whole network, which you see here in controls, in parietal lobe, lateral premotor cortex, and parahippocampal gyrus, but she could reliably activate this area in the parietal cortex. And that's what's important, really. You don't have to activate the entire network, and that's because, you know, these patients are often extremely severely brain damaged, and it's quite understandable that some areas of their brain will not be responsive. But if a patient can reliably activate an area of the brain every time we ask them to, in this case, imagine moving around your house, and it's sufficient for us to deduce that there's a residual level of awareness that isn't apparent from behavioral observation. As you can see from the graph at the bottom here, this patient was very able to imagine moving room to room in her house for 30 seconds and then relax for 30 seconds, imagine again for 30 seconds. So this is something she could repeatedly do. Despite her very serious injuries, this patient recovered, and a few months after the scan was actually able to go home and survived her injuries. So again, I mean, this is, I think, pretty amazing that some patients who appear to be comatose in the ICU, actually, we can show have some evidence of residual awareness, and it has prognostic, it is prognostically useful. What about using the movie task? Well, coma patients, as I've already said, have their eyes completely closed, so you can't ask them to watch a movie. But it turns out this technique works pretty well if you listen to an auditory track of a movie, as long as it's something that makes sense. So we've been using a scene from the movie Taken with Liam Neeson. If you've seen this movie, it's the scene where his daughter is under the bed. There are kidnappers in the house about to kidnap her, and she's having a conversation with her dad, Liam Neeson, about, you know, how she's going to avoid getting kidnapped. It's extremely tense, 5 or 6 minute scene. You can follow it very easily, whether your eyes are open or closed, whether you can see it or whether you can just listen to it. Lorena Narchi, again, now at Trinity College Dublin, did a study looking at this task, verifying that it works, and showing that it's affected by sedation with propofol. There's the auditory network when you listen to, these are healthy participants, listening to the Taken soundtrack, very little changes, as we've seen previously, in the auditory network. And this is speech perception, sound perception, all the rest, when people are sedated with propofol. But the correlation in frontoparietal cortex is absolutely obliterated as soon as people are just mildly sedated. And I think this is the closest sort of neuroscientific evidence that we, or neuroscientific version that we have, if you like, of losing the plot. I mean, this is exactly what happens as people start to detach themselves from following the plot, as they start to lose awareness, as they're sedated with propofol. We see activity in these fronto and parietal areas reduce. And just as I've shown you previously, we can use independent component analysis to pull out this network. And then we can go to patients, we can play them the Taken movie, and we can say, hey, let's see if there's any activity, any correlational activity in frontal and parietal cortex when they are listening to this movie. And because we know that this is indicative of them actually following the plot, rather than just lying there having the movie sort of wash over them and have it automatically processed by the brain. And here's a patient, again, in the ICU, comatose patient. And I should emphasize, we only have one patient that we've seen this in so far, but it's been a relatively small group. But this patient, whilst listening to the Taken soundtrack, despite apparently being in a coma, being in the ICU, was able to show activity in fronto and parietal cortex that was very tightly correlated to the pattern that we see in healthy participants when they're in the scanner listening to the Taken soundtrack. we concluded that this patient isn't as unaware as they appear to be. And just like the previous patient I've shown you, this gentleman did recover and actually was able to return home several weeks after this scan. So hopefully I've convinced you that this is going to work. We have some decades of experience in chronic vegetative patients now, and that's very much established. This is all work that's been done in the last 2 years. It's still in preparation, in submission, but I'm very confident that we're going to see exactly the same patterns in comatose patients. We're going to be able to re-diagnose patients, find patients who are actually aware when clinically they don't appear to be, patients who are able to show that in some cases, like these 2 patients that I've shown you, it is prognostic. It can tell us who is likely to recover and who isn't. Of course, that's tremendously clinically important. But what about communication? I'm going to end now. It's my last couple of slides. Recently, in communication in these patients, it seems like a real pipe dream, science fiction, if you like. Could you possibly communicate with a person who is totally non-responsive in the ICU? Well, I think the answer is yes. We're not going to be able to do it with fMRI because fMRI it's dangerous in this patient population. Moving them to the fMRI it's very challenging for us, but it's also very dangerous for them. They're extremely vulnerable. We've moved to a technique called functional near-infrared spectroscopy, or fNIRS. This is essentially the optical equivalent of fMRI. The benefits are it's completely portable. We can take it to the bedside. We can do whole brain coverage. As you can see here, this is one of my former graduate students wearing our fNIRS kit. We do whole brain coverage. We're again looking at hemodynamic response as much as you are with fMRI. And as I say, we can take it to the bedside, and it's much safer for the patients. Again, one of my current postdocs, Andrew Abdelmalak, has done a lot of work using time-resolved fNIRS. And he's now seen 3 patients in the ICU with Guillain-Barré syndrome. As many of you know, this is an autoimmune disorder. It renders some patients completely immobile, completely paralyzed, but actually still conscious. And in many cases, these patients are sedated because during the period of unconsciousness. And this is a condition that some people do actually recover from. So it's a temporary period of paralysis. But obviously, this is an extremely unpleasant and possibly quite terrorizing situation to be in. So frequently, it is the case that patients in this condition are sedated. The first patient that Andrew saw had actually elected not to be sedated. And some days into his behavioral non-responsiveness, the clinical staff were concerned that perhaps he didn't feel that way any longer. Was he comfortable? Was he okay? And so Andrew went in with the fNIRS and asked him a series of questions using a simplified version of our communication technique. And you don't need to understand fNIRS data to understand this. We're simply looking for a difference between the red and the blue lines, the oxyhemoglobin versus deoxyhemoglobin. What Andrew did is he simply asked patients to imagine playing tennis if the answer to a question was yes, and to do nothing at all if the answer was no. His baseline, this is doing nothing at all. There's no difference between the oxyhemoglobin and the deoxyhemoglobin. I should have said this is just with detectors over the premotor cortex. Another great thing about the beauty of fNIRS is that you don't have to look at the whole brain. You can just look at, in this case, the premotor cortex, because that's the area that we know is involved in imagining playing tennis. Now, when this patient in the ICU imagined playing tennis, there was a clear departure of oxyhemoglobin versus deoxyhemoglobin. He's clearly able to do this and produce activity in his premotor cortex. Andrew then asked him a series of questions, things like, are you in any pain? No response. That's because he's doing nothing. He's not imagining playing tennis. The answer is no. What about, do you feel safe? Suddenly, there you see the difference between oxyhemoglobin and deoxyhemoglobin. Here, he's imagining playing tennis. He's saying, yes, I feel safe. And Andrew went through a series of questions with this patient. Remember, this guy is absolutely behaviorally non-responsive. He can't twitch a finger or blink an eye or do anything. Yet he was able to communicate in the ICU after some weeks of being in this situation. And as I said, we've now seen 3 patients like this, 3 patients in the ICU who are completely physically non-responsive, but have been able to answer questions using functional near-infrared spectroscopy. So that's really the summary of my talk. It's the end of my talk. I must just, acknowledge some of the many people that have worked with me over the years. I have many extremely talented collaborators. graduate students and postdocs. I haven't listed everybody here. I've tried to focus on those people who have contributed specifically to the work that I talked about today, but none of it will be possible without any of them. Also, I've written a book, Into the Grey Zone. It's available in many, many languages now. It's not strictly a science book. It's a popular science book, if you like. It describes this journey of discovering or looking for this lost population of patients, if you like, the various techniques that we tried, how we developed them. And it's sort of wrapped up in a series of stories about the patients themselves, because, most important of all, I think it's the patients and their families that contribute to this work and really have made it possible. So I'd like to thank them at all and encourage you to, if you want to learn more about this work, to go ahead and read the book. In the meantime, many thanks for attending, and I'm very happy to answer questions. Thank you.
I worked in Cambridge as a clinical neurologist at the time you were there, and I well remember the excitement of the papers. My question for you is, in retrospect, are there any indicators that we can look for without having to put patients into fMRI scanners that will tell us whether they fall into the 20% who might respond versus the 80% who don't?
Yeah, that's a great question. So I'm getting some feedback. Let me just turn my volume down a bit. Well, not really. I mean, I think the answer is that we will find easier ways of doing the same thing. I think fNIRS is a good example of that, where you don't have to transport the patient to the scanner. You don't have the whole rigmarole of getting them carefully positioned and asking them to hold still. So fNIRS is a much cleaner technique in that sense. And to be honest, we are getting the same results. So we've been using fNIRS in chronic patients as well, and basically we see the same things, but it's a heck of a lot easier. So no, looking back, I don't look back and see these patients that were able to respond and say, well, if we just focused on that clinical feature that we'd missed before, that's not happening. I do believe that many of these patients are completely clinically non-responsive, and there's no evidence, unless you can get into that, get to look at their brain, there's no evidence that they're anything else.
Thanks. Two at the front. Maybe I can just ask a question while they're doing that. I often get asked by the ITU team, we've got someone who's come in and they're not responsive, and it's 2 days later or 3 days later, and they're saying, well, what do we do? Do we say we're going to pull out, or do we keep going for a bit longer? Is there a time when you say, well, if we don't get any response beyond 4 days or 5 days on some of your techniques, then actually it's not going to happen? Or can you not really be as definitive as that?
Yeah, I think you're actually talking into the future. This is obviously going to happen. And that's really what we're aiming to do. Can we actually come up with new prognostic indicators and ultimately say, this person has a very good chance of recovery, this person has a very low chance of recovery based solely on the imaging data. At the moment, as far as I know, none of this is standard of care in any jurisdiction. We work very closely with our clinical colleagues in the ICU, and I can't honestly say that they don't take any notice of what we do. They certainly do, but we obviously have to be very careful because it isn't standard of care. So I think we're at very early stages, but there's no question in my mind at this point, given the history and what has evolved in the chronic patients over the years, that we're going to move quite soon into a position where this will be affecting decision making in the ICU.
Okay, thanks. John?
Yeah, I just had two quick questions. One was that lady who responded to the Taken soundtrack when she was in a coma and then recovered. Did you ask her whether she could remember it? Did you play it to her and say, does this sound familiar? That was one question. And the second one was, have you ventured to ask these patients with severe super locked-in Guillain-Barré whether they want to change any aspects of their care or even have their care withdrawn?
Yeah, so let me try and hold both questions in working memory. The first one, in her case, no, she didn't have a clear recollection of what had gone on. That's quite common, although we have had patients who had an absolute perfect memory at many, many months, scanned them. There's a case I wrote about in the book. We've never published it because every time we try to publish this, people say, hey, we want a whole group of patients who can recover from the vegetative state and remember it. There's a single case study. It was here in Canada. We did everything with him, and 9 months later, he had recovered to the point that he could come back to Western, to here. And we interviewed him, we asked him a series of questions. And not only did he know the answers, I mean, there were questions like, do you remember the name of the person that put the EEG cap on you? And yes, he could have just said, yes, it was Steve, but actually he answered like this. He said, yeah, it was Steve. Steve is one of your graduate students, and he had a very deep voice. So he would actually give Steve was a graduate student that did have a very deep voice. He would give all of this additional information about, you remember the colour of the electrodes on the cap, you remember where the MRI scanner was, who had scanned him, the name of the technician, absolutely crystal clear memory 9 months on, actually much better than my memory had been of scanning him on the day. And I said to him, how do you remember all this stuff? And his answer was, well, I had nothing else to do, did I? And he was so convinced that he was going to recover that he just lay there remembering everything. So, I mean, these people come along once in a blue moon, but, you know, we do have this one place of a person who can describe everything. But more usually, people have sort of hazy memories that they say, you know, I remember, you know, this and that. It's not very clear. But of course, they, you know, especially in the ICU, they have an awful lot of stuff going on. They have an awful lot of scans. And it's perhaps not surprising that they don't remember the details of anyone in particular. Actually, I've forgotten. Your second question has now dropped out of my working memory.
Asking end-of-life care.
Yeah, it was to ask if anyone had said anything about their end-of-life care while they were communicating with you.
So, no, we haven't got that far ethically with actually asking that. I mean, with the Guillain-Barré patients, we do spend a lot of time asking them things about their level of comfort. You know, are they scared? Are they in pain? Do they want to be sedated? These sorts of things. And that's working sort of clinically really well, I think, in the sense that I feel like we're actually doing something, and the attending staff are very receptive to this, you know, in that case. But of course, they're an interesting group because we know that they are aware. You know, that it's not really a mystery that a Guillain-Barré patient is sort of locked in, if you like. I think, you know, starting to move in this direction with, you know, patients that we discover are aware when the evidence suggests that they aren't, and moving towards questions about end-of-life care, I think it's inevitable that this work is going to go in that direction. We've published a few papers recently, sort of ethics papers, describing the process that we think we'd have to go through to make that happen. Because, you know, it's not as simple as saying to somebody, would you like to live or die? Because, you know, quite appropriately, I think in most civilized societies, we don't allow people to decide they want to die. You know, you need to go through a series of questions to assess, you know, how competent somebody was to make that decision. Is this a permanent, much as you would with anybody that had, you know, somebody who's obviously conscious but had some sort of psychological challenges. You'd want to make sure they understood the, you know, the implications of what they're asking you to do, and so it would be complicated. But, you know, these are details. I think the technology is there, and it's going to be up to the ethics committees and the various regulatory bodies to decide, you know, how and when we can deploy it in those sorts of ways.
I think, in the interest of time, just one more question. So, Katerina, and then I think we'll have to draw it a close, I'm afraid.
Thank you for this. I just want to say, maybe it's naive, depending on the damage, but in the patients, the minimally conscious patients, that you get them to imagine playing tennis. You know, we know from the good old days of Jean General that motor imagery can have some effects on the periphery that are similar to action itself. So could you not use that as a signal, verifying it by the fMRI, but then not needing it every time? And they not can you, for example, play tennis for 40 minutes, you're likely to have different heart rate, and you're likely to have all sorts of different autonomic reactions. So can we not use that? Or are they not responding?
That's a really great question, and we've tried a few things actually over the years. We've been we were quite successful with a couple of patients looking at galvanic skin responses while they watched a sort of a slightly tense movie. And, we found that you could actually, the GSR would track in much the same way as the fMRI did. Similarly, EEG, again, a little bit easier to put an EEG cap on somebody than to put them in an fMRI scanner. And we're getting fairly similar results with EEG, with the movie watching. A graduate student at the moment working on that, and it's proven to be quite successful. Heart rate we've never tried, but I'm quite sure that you probably could pick up a signal that you could use. The only thing I would say is, it's all going to be more noisy. I think we got lucky with the fMRI. We got lucky with the choice of task. We got lucky with the technology, and it just happens to work really well. And it works really well for a number of reasons. One of them being, you've got the anatomy right there. You can superimpose the functional data on the structural data, and it's relatively easy. This is going to sound a little bit unbelievable, but it's relatively easy to say yes and no, this person is imagining playing tennis. We do it in real time now. The person is still in the scanner, even on the scanner console itself, with the fairly rudimentary analysis methods that the scanner comes with. You can tell that somebody is playing tennis in the scanner. Everything else requires that you go away and you dig through the data and you average things. And I've yet to come up with another approach that, despite the fact that putting somebody in a scanner is quite complicated, the data is extremely robust, and getting robust data in single participants has been the biggest challenge of the last 25 years, really, because a lot of this stuff works very well in group studies, but when you want to determine whether a single person is responding or not, it's hard. And fMRI has always just returned more robust results than any other approach. But I'm sure you're right that there are likely to be other things we could use.